Hi, everyone, and welcome to the first webinar of the EANS Research Committee. My name is Catherine Rabi. I'm the chair of the EANS Research Committee, and I want to welcome everybody who is here to join us for the webinar. So we have an exciting webinar series for you in store. Today, we're going to start with sort of a kickoff webinar discussing multi-center studies, translational to cross-sectional studies, and then research on training models. And later on, we will have a webinar discussing publications in neurosurgery, randomized trials, and then AI in neurosurgical research. Some of the webinars we're going to host and collaborate together with EANS IM committee. So that's the individual members committee. And today I have my two colleagues with me, Professor Akilakso and Professor Sajjad Mohammed, who are going to moderate the talk. And we want to ask everybody to put their questions in the Q&A box. So not the chat box, but the Q&A box, and your questions will be then answered and discussed at the end of the webinar. So with that, I'd like to welcome everybody and welcome my colleagues who have kindly joined to teach us more about neurosurgical research. So.
Welcome everybody from my side. Also, my name is Sajjad Mohammed. I'm working at University Hospital in Düsseldorf and will be moderating this exciting webinar together with Aki from Helsinki. Welcome everybody again to this exciting webinar series. Would not lose too much time and would introduce our first speaker, Harald Krenzlin from Germany, with the topic from translational to cross-sectional studies. Harald, you can start with your presentation.
All right. Thank you so much for the kind introduction, and hello everybody from the north of Germany. So my name is Harald Krenzlin. I'm working at the UKSH in Lübeck. I'm the senior attending here, and I have the great pleasure to tell you a little bit more about translational research and cross-sectional research in neurosurgery. So disclosures or conflicts of interest, I have none. And let's go right into it. So I've read an intriguing paper a couple of weeks ago, and the title was "The Answer 17 Years, What is the Question?" And I think this leaves many things open and many things to discuss later on. So what is the question? Translational research is a term that came into the forefront of research and the medical minds in the beginning of the 21st century. So it's not that old, it's a kind of young term. And it came into being in a time where biomedical and genomical advances were actually not translated into positive human health impact. And the Institute of Medicine, which logo is shown on the right corner of this slide, hold a series of roundtable discussions. And it was actually a best of 3 series. And the minds attending these roundtable discussions came up with the definition of so-called translational gaps. They defined at least 5, T0 to T4. But in the very first discussion, they came up with T1 and T2 translational gaps as a bottleneck. So what does it mean? So we need to learn, or we need to know a little bit more about what translational research actually is. So nowadays, there's even research on what this term means and how it's been used in science today. And I find interesting how complicated a figure could be just looking at such a simple term at a first glance. And what you can see is that most of the authors, looking at different studies from different authors over the years, they all agree on what T1 is, the T1 phase of translational research. But the agreement is becoming less and less if it goes through all single steps that in the combination form our understanding of translational research. Translational research is something that concerns as a concept actually, and established over a decade ago. And now it seems, yes, it works. And is defined as a series of necessary steps to make an interesting idea, a good idea, or breakthrough research advances count for the community as such. And if you want to put it in more simple terms, what translational research means is from bench to bedside and back again. So what is T0? T0 is the phase, or so-called identification phase. It means you have to identify a problem, a need, and an approach to solve this problem or to meet this need. But the T0 phase also wraps back from what has been already achieved, confirms that, is generating novel ideas out of what has been already done. So it's kind of a wrap back to basic research. And therefore, it might also involve genome-wide association studies in combination with thinking about problems or community research. T1 then means from bench to bedside research, actually. So what we understand as basic science, development of validation of animal models, cell culture, of developing preclinical drugs, and develop new and clinical relevant technologies for future use. And you put this in phase 1 and phase 2 clinical trials. This all comes together as T1 of the translational research. In T2, you take what has been achieved in T1 and take it from bedside to practice. So this is the actual phase of studies in phase 3 of clinical trials, for example, and also includes comparative effective trials. And it also might be that phase 4 clinical research trials are still T2 translational research. And also in this phase, you develop the development of clinical guidelines takes place. And if you progress further, if you disseminate and implement what has been achieved in T2, then you're on T3. Studies that aim to spread the knowledge that has been tested in humans and in patients, and is regarded as evidence-based interventions or dissemination research. And also in this phase, you have the integration of the interventions into existing programs. It's kind of implementation research. And then you progress to T4, and you have the diffusion research. So you see how your research accomplishments, how your ideas, how your novel practices diffuse in a community. And if so, if they are good, spread good to a larger number of people. And it's focused on outcomes, effectiveness in a huge or in larger populations. It's assessment of public health policies and programs, and the adoption of best practice on a community level. It might also include cost-benefit analysis on this level. And then it goes back to T0, and you circle back to basic research. And applied to neurosurgery, I think there's no better example than the 5-ALA for what translational research, including all these steps we've learned about and that's been researched in one development, in one achievement that's been used by neurosurgeons all around the globe today. So 5-ALA, a non-proteogenic amino acid, as a metabolic precursor of heme biosynthesis, and is excited by violet and red wavelengths of light. And what it looks like, if you have it in a tumor patient, then you have like this white light anatomic view. And if they've been given 5-ALA and you excite the brain with a distinct wavelength, then you see this reddish glow distinguishing tumor tissue from normal healthy tissue. And going back to our phases of translational research, 5-ALA came to the forefront of the scientist or scientific mind in the 1990s, when 5-ALA was described a lot and tried for photodynamic therapy in various kinds of tumors, actually. And then in 2006, very smart neurosurgeon came up with the idea that it could be used actually to distinguish gliomas from healthy brain tissue. And he put in a phase 2 clinical trial very early on at its translational research in 1998. And because it worked quite well, actually, in a sense, he progressed to a phase 3 multi-center clinical trial in 2006. And because the achievements were so astonishing and it worked so well in a sense, that at first the European Drug Administration in 2007, and later on the FDA approved 5-ALA for glioma surgery. And where are we now? We're still doing research now on a more community or population-based approach. So like this in 2022, where we had like this cost effectiveness analysis of 5-ALA in high-grade glioma surgery. And from there, novel research topics are generated on a more or less weekly basis, how it could be used, what other benefits could be used or leveraged of 5-ALA. And this makes or closes the gap to T0 again, where the whole translational circle might start all over. So by now, what is the answer to this? What's the question to this answer? 17 years. It's about the translational time it needs for an idea to bear fruit and to like gain benefit for the whole community. And the subtitle of this paper actually was Understanding Time Lags in Translational Research. And this is where these initial roundtable series steps in. And these are the defined gaps in translational research. The T1 gap after T1s, that ideas are not translated from the animal model, from cell culture to clinical trials. And larger clinical trials are not implemented on a daily basis, on a routine basis. But also sometimes the ideas suffer setbacks because they're not cost effective, or because the ideas never ever get generated or make it to the early research phases. Okay, by that, I would like to share just a little bit of my experience very briefly. So this is where we work. This is our hospital here in Lübeck. And what I actually practice and what I experience on a daily level is that neurosurgeons are in a kind of pinnacle between all the clinical research and the basic science research. And in a larger hospital, in an optimal setting, then you combine all these possibilities of basic science, clinical research, together with our surgical experience in kind of a laboratory, in maybe in a different building, maybe in the same clinical building. But this is where it all comes together. And this is where translational research and cross-sectional research, this cross-sectional research to me is just another form of translational research, actually, where it all comes together. Because in such large hospitals, you have the young academics doing the basic science, going through the ranks. You have clinical specialties, you have external collaborators. And this is what's been needed for cross-sectional translational research, if you want to put it in this way. You have all these departments treating the same patient, actually, making good neuroradiology images, aiding the oncologists, the radiotherapists, the pathologists, the virologists, the genetics department, the pediatricians. But also, you need to think outside your own hospital, outside the departments that are there for you on a daily basis. And you collaborate with other universities, see if they're doing the same research, see if they're having the same ideas, encounter the same problems. And you don't only do this on a medical level, you might also do this with technical universities. Like we have like a strong collaboration with the Frankfurt University of Applied Sciences to come up with novel ways for technical devices and implants. But you also have like these external collaborators who are doing this kind of research on a monetary basis, like the Fraunhofer or the IKF, the Max Planck Gesellschaft, which are strong and necessary nowadays. So what are we doing? So how does translational research look in a hospital like ours? So we're doing all these big data analysis with the tumor samples we derive from our glioma patients, for example. We do RNA-seq analysis. We're doing these comparative gene expression analysis. We're doing TCR-seqs, like to map the immune environment. And all this is to come up with ideas how we could improve the treatment of our patients in a very early, like T0 or T1 phase. And once we've identified like novel targets, for example, for therapeutic ideas, for or improve the understanding of our pathophysiology, we progress, we go to our lab, bench side research. And in this example, for the TCR-seq analysis, for example, it was kind of intriguing that we found that 60% of the epitopes in glioma are associated with CMV. So this idea made us look in our patients and see if they're never been CMV infected. So the tumors are actually are negative for CMV. And in the seropositives, we see a strong CMV expression in these tumors. And from there, we got into a mouse model where we infected black 6 mice with CMV viruses. We implanted glioma stem cells, saw the tumor grow, and saw that in the background of CMV infection, these tumors grew quite differently. We did MRI with the colleagues of the neuroradiology department, saw differences in the perfusion of these tumors in the vasculature. And we saw that if we treated them within virostatic drugs, cidofovir, for example, these mice tended to live longer and had a survival benefit. And this is what could be translated into something that counts for the patient in the T2 phase, for example. But in order to do so, you need to have your research very close to human cells, to patients. And for that, we actually transfected mouse cells to express a human HLA antigen for presenting viral antigens, made them, we humanized these mouse glioma cells. We implanted them, and then we took a mutated CMV virus, which is for the mouse, or like mouse CMV, but expressing human CMV antigens, which are then presented by this human HLA. And by this puts us into the great position to treat these mice with T cells that are actually recognizing the human antigen. There's also transgenic T cells with a T cell receptor that recognizes these CMV antigens, but the human ones, because these viruses mutated. And this is something you could directly transfer to human models, to human glioma stem cells, because you could use these cells likewise then in your mouse model and in your human cells. And if it works there, there's like encouraging results, as there always is. Like here, if you incubate your infected glioma cells with these T cells, you see these glioma cells lyse, and you're now on the brink of bringing these therapies into patients, actually, and doing very early on clinical trials. But this is not the only way. So you don't have to come up with something completely new. You could also take this big data research like we did in this RNA-seq analysis. You cluster it, you match it up with the TCGA atlas to compare it with more samples of persons that were doing the same. And then you could find subtypes of glioma that might, for example, profit from immune checkpoint blockade, whereas most, I think we know, most gliomas don't, but there's a subtype that does. And if you have this information, if you have it like on a statistically significant basis, then you could progress to design clinical trials. This is a clinical trial we actually submitted to the Deutsche Krebshilfe, where we wanted to take the checkpoint inhibition to a neoadjuvant stage and then progress and compare it to CCNU, which is the standard of care in our hospital for recurrent glioblastoma, and then see if this approach that we've learned during the T1 analysis of our samples, if it actually might benefit our patients. And I would actually like to end my presentation here, and as a take-home message, I would say from my side, translational research needs a tremendous amount of hard work and consistency, which is kind of hard to come by in neurosurgery because we're always busy, but this is what it takes to actually take brilliant ideas that almost every of my colleagues has, from T0 to T1 to T2, and maybe put them into something that numerous patients could benefit from. You need a strong network of scientists, clinicians, and industrial partners to actually make your ideas count and work. And you need to avoid these translational gaps, and you need to avoid to get stuck during the phases of translational research. And the more you know about these processes and what it takes to come from one step to the other, and that you can't take one step before the other, then the more you might be able to circumnavigate these gaps and actually have something out of your clinical research or basic research that our patients might benefit from. I would like to say thank you and then quickly hand over to the next speaker.
Thank you, Harald. Very interesting and inspiring talk. There are no questions at this point, and I guess we actually mentioned that it might be good to go through all the questions and discussion at the end. So I invite the next speaker, Markus Wiedmann from Oslo, Norway, who will talk about research on training models. Please, Markus, go ahead.
You are muted.
You are muted.
Now you can hear me? Oh,
Yes.
amazing.
Yes.
Perfect. Thanks, Aki, for this introduction. And thanks, Harald, for this inspiring talk. So what I want to do, I want to keep this rather basic. I guess this is mostly a webinar for trainees and young neurosurgeons. And I want to talk a little bit about how you could integrate research into neurosurgical training. Let me see if this slide, yeah, now it works. You can see the slides, yeah. Perfect. So obviously, as a trainee in neurosurgery, you're mostly interested in getting the best training to become a proficient neurosurgeon. That's what most of us, at least, are aiming to. And this is becoming more and more difficult because of decreasing caseloads, because of increasing subspecialization, and so on and so on. Also, steep learning curves and all the issues we all know about. But there's also another issue, and this is how to combine academic work with an excellent clinical training program. And that's actually a known dilemma for many of us. How can you actually combine or balance the demands of acquiring your surgical skills with the expectation of your contribution to academic work? And also our traditional training models, they often lack structured opportunities for trainees to get involved into research, but at the same time to participate in an efficient and good training program. But there are also opportunities because there could be more encouragement in participation in simulation and training, research and training, which could both provide practical experience in research, performing research, but at the same time you can contribute to your surgical training. And this is actually something that hasn't been so much in focus, and there's a lot of lack of research in neurosurgical training. I mean, we all have been to cadaveric courses, for example, and obviously everybody knows that it helps to do cadaver dissections, but there's hardly any scientific evaluation or evidence about how effective cadaveric courses are, how they should be set up, how often you should do them, when you should do them, and so on and so on. Then we have the evolving landscape of a lot of other neurosurgical training tools, simulation models, all the VR-based technologies and so on. And it's very uncertain how the different models actually enhance your surgical proficiency and what of the models are basically funny toys to use. The other issue is that it's actually quite difficult to measure the efficacy of training. So let's look again at the cadaver labs. How should we actually measure if the cadaver dissection translates into better surgeries and so on? It's not so easy to do that actually. The same applies for simulation trainings. I mean, you could do a lot of simulation models, but the question is, do they really transfer to an improvement in real surgery? And how should you measure it? There are other examples of procedural skills, for example, the ATLS courses or what neurologists do, the stroke trainings. where they go through drills. And that also has benefit, but only if you do it repeatedly. So if you only participate in one ATLS course and haven't been there for 10 years, obviously the benefit is not there anymore. And in a broader context, this also applies to the whole residency curriculum. So how is it set up? What parts of the curriculum are actually evaluated that they work the way they're intended to, and so. So basically, the question is, or the topic is to evaluate the efficiency and the value of our neurosurgical simulation training models, especially now where we have more and more very high-cost systems. And this is very important for the debate about modern education. So let's go back to the question of how can we measure the effectiveness of simulation models. There are different types of validity that you can assess. So the one thing is, for example, what is called face validity. So does the simulator basically look and feel realistic? Then you have content validity. Does the simulation model include relevant anatomical and other practical elements? There is construct validity, meaning can it distinguish between a novice and an expert user, or concurrent validity, which means does the simulator actually, the results actually correlate with other validated measures? So if we at all have that. And then in the end, what is most important is, of course, is their predictive validity, which means can performance on the simulated system predict real-world surgical outcomes or not? Because this is basically what we're interested in. So predictive validity is obviously the gold standard. Then there's a question what to measure, and there are again a lot of discussions about that. So there are different performance metrics. You can always measure the time to complete a task. You can have a look at error rates, complications. If you do suturing, you can, evaluate the quality of the stitches and so on. Instrument handling in the haptics models. So you can evaluate the force that you apply with your fingers and so on, or with EVD placements, you can look at the accuracy. But it's not always enough to look at these very specific things, but I think it's also important to supply with maybe subjective measures, which could be expert evaluation or even a structured supervision by an expert or a senior surgeon. Another important issue for training is, of course, money. So training is expensive, and we have to think about cost effectiveness. So there are a lot of systems that have been applied now, VR systems, high fidelity simulators, which are really expensive. So they often cost 200,000, 300,000, 400,000 euros. And the question is, are they really worthwhile the money or not? This does not only depend on the type of simulator, but it also depends on, is the simulator actually used a lot in hospital or not? Is it integrated in a curriculum? How do you measure the learning outcomes? And then also, again, importantly, if you do simulation training, do you have faculty feedback, supervision or not? Because you can train a lot, but if you train the same mistakes over and over again, you're not really improving. And then it doesn't necessarily mean that an expensive system is the best system. So cost effectiveness can vary a lot, and some low-cost models may achieve similar or even better educational goals in different training stages. These are just some examples of different training systems that have been implemented over the last years. So some of them are commercially available, some of them are not. And again, cadaver labs we have been doing for many, many decades. And this is a picture of some different models. So on the upper right, you see a homemade model. So this is what we use, like a placenta model. And then below you have a department that has set up a simulation kind of center. And then to the left, you have two commercially available simulation systems. So these are companies that are selling ready-made systems to your hospital. So in the end, I just want to walk you through an example how you could set up such a research training kind of system. So let's just say you want to develop a training model for endoscopic transsphenoidal dural suturing. So you want to close the dura with sutures in an endoscopic and endonasal surgery. Of course, first you have to identify the gaps of knowledge. In that case, it would be like lack of validated suturing models or insufficient objective outcome measures, and so on and so on. So you, again, as you do with all research, you have to pose your research question: how effective is our model in improving dural suturing skills in endoscopic skull-base surgery? And you basically follow the PICO format as you do for other studies. So this is actually the same. You always have to do a literature review and check what is already done in your field. That's also the same as you would do for every other research. Then you have to choose a study design, which again depends on your goals. So do you just want to develop a new model and validate the model? So validate the realism, the phase, the content, the construct validity. Or do you want to combine different performance metrics with qualitative interviews and surveys? Or you could do a controlled trial where you actually put people through a training, people at different levels, and then you can measure how well the model performs at several levels. You have to choose your metrics for evaluations. You can choose objective metrics like time per knot, or how much instrument collisions you have, if the dura is watertightly closed or not. And then also very important is to evaluate the impact and the scalability of your model. So can others reproduce your model easily or not? Is it complex? Is it low cost and easily accessible, which is important if you want to have a broader impact? And could it be implemented as part of a standardized curriculum or a residency program? And if you can do that, then you have a good chance of creating a high impact project that actually may influence training standards and in the end maybe care. So this is an example that I just found a recent paper on such a model by a Japanese group, a very smart training system, which is super cheap. So you buy all of these items in a $1 store, put them together, and you get quite a realistic suturing model, similar to endoscopic closure. I mean, this model, if you evaluate it by these topics I just discussed, so realism would be simplified or abstracted, so it's a low fidelity model. It would be inexpensive, so that's good. Application is actually for complex suturing skills, and learning stage is probably both for intermediate and also advanced trainees, and not only novel or novice learners. So this is basically what I wanted to show you guys and get a discussion going. Training in neurosurgery is largely experience-based and very much under-evaluated. I think we have a responsibility not only to train, but also to validate our training. And if we can show scientifically that more intense structured training improves safety and outcomes, we can argue more strongly for protected time, institutional funding, and also policy support. Thank you very much.
Thank you, Marcus, for an excellent talk again. We continue with the next talk and gather the questions for the final round. Our next speaker is Vanessa. She is a consultant at the University Hospital in Berlin, very active in multi-center studies, and we look forward to her talk, multi-center studies in neurosurgery.
Thank you so much for the kind introduction. Yeah, I'm happy to talk about how to design a multi-center clinical study today. My name is Vanessa Hubertus, and I'm a neurosurgeon at Charité Berlin and also a clinician scientist. So, how to start? At first, it is important to find a topic that inspires you. For me, this is the spinal cord and also spinal oncology. So it does help before starting to think about multi-center projects to build a publication record. For example, I was able to participate in studies where I had very experienced speakers who were helping me to get started. Sorry. I was having some technical problems. Can you see my screen again?
Yes, we see.
Thank you, and sorry. So yeah, I was very lucky to, at the beginning of my career, to have found like a friendly researcher who's already very experienced in multicenter studies, and I could join my research with her. So it was possible to send some data and to get multicenter projects going. And then it is important to start to formulate your own research question. So you should start with patient, population, and problem, intervention, control, and outcome. This is the PICO. So how did I start? The first thing, what would like to interest me in my clinical study? It is how to treat multiple myeloma. And why? Because I found a gap in the literature together with my team. We do not know when and how to operate on multiple myeloma patients, and if, then when and how is the outcome depending on surgical strategy, aggressivity, or timing. Then the intervention. Should you operate at all? Yes or no? Control and comparison is like surgery, yes or no? And outcome. What should I measure with my research? Possible outcome parameters are like survival, standards of treatment, indications for surgery, timing of surgery, pain, health-related quality of life. This is all very important to think about before you start planning your research. And it is also dependent on the primary research question. So how to formulate this research question appropriately? It is very important to do the necessary groundwork, the systematic review of the literature. As you might know, there is a PRISMA statement, which is very important to do the groundwork for your research. You do not want to do anything that has been done before, so you need the systematic review, although it is a lot of work. If you do it properly and you have found something new, it might be also of interest to publish it. So it's to think about. First, you have to identify what has been done before. You have to categorize it, and you have to like make it concise to build a new and well-informed research question. So this is what we did at first. Before we designed the project, we did the literature review, and we know that we have a high incidence of multiple myeloma. In more than 50% of cases, we have vertebral lesions. They go together with chronic pain, neurological deficits, and are nonetheless perceived as a non-surgical disease in most parts of the world. So we found that there is no consensus for optimal therapy, surgical strategies, or the timing of surgery. This was the background. When you look at the background in oncological trials where they say, okay, what is the treatment algorithm for these patients? You can see that we have a very small, very small data, or there is more recommendation ground for surgical therapy. So this, I think, is a good gap to start. And then it is important to choose the adequate study design with which to address this question you have identified. There are different types, like retrospective cohort studies, prospective observational studies, or prospective controlled trials. You always have to think about, is it feasible to answer your question with this design? And yeah, think about the PICOs. So for example, for me, this was first a retrospective cohort study to get started because we had the data and we could look into it. And looking at survival, standard of treatment, indications for surgery, and timing of surgery. Then we added a prospective observational study looking at the influence of surgery, timing of surgery on pain, health-related quality of life. Observation is meaning here that we do not influence the standard of treatment. We just look at the standard and we collect the data to get a good basis. And then the next step would be to build a prospective control trial. It could be, for example, the influence and timing of surgery, also on pain, health-related quality of life, but then you would have to develop a treatment algorithm before starting. So this was what it was looking like for me. So we had 3 packages. Package 1 was our M2 spine registry. It's like a retrospective cohort study, multicentric, just to collect data of the actual standard of care. Package 2 would be a questionnaire to get to know what do experts think? How should one treat these patients? Is there a consensus or is there really no consensus at all? This we just have finished. And the next package would then be the prospective observational study. And it is very important to find funding for all this sort of research. So how do you then build your collaborations? I think it is very important to have a good database. It is important that it is easy and accessible, concise. This must be especially designed to answer the research question. I know it is nice to have lots of data, so maybe you can do something with it later, but that the partners are compliant. It is important that the data is focused and you cannot ask 100 questions. It will just not be filled out properly. It must be easy to use and easily available. Ethics and paperwork are the groundwork. You must have ethical institutional approval, make a data protection plan, and acquire international or national contracts for collaboration. Have them legally checked before you start a collaboration. We at Charité, for example, we have an institutional clinical trial office and IT support. So it is very good to check this before that you have everything before you get it distributed. And it is also a good idea, I think, to distribute an authorship and data availability plan beforehand, so everybody knows where the data is going and what's happening with it before they give it in. And an approximated publication plan, so everybody is on the same page. And then it's also important to have funding. You have to check the necessities for data monitoring, what personnel is necessary to get the research going and also the results in. To keep it relatively low cost, you can work with young colleagues or students, but it is also good to have a study nurse who knows how monitoring is working, just to have everything in order and apply for funding. So we did it, for example, with the Red Credit program and got supported by the Berlin Cancer Society. Then as the next step, if you have built collaborations, you have an idea and all these steps are done, it is important to get your study registered. It is important for the visibility, but also for the publication. Lots of high quality journals, they do not accept studies that have not been registered before patients are enrolled. Also you need funding because otherwise maybe you will fail because you do not have the support you need. Platforms where you can register it. Internationally, it's clinicaltrials.org. In Germany, it's, for example, DRKS, it's for clinical studies. Here we have registered ours. So it is also good to be concise about the necessary work packages and when the study is rolling, to stay reachable for questions. I think it is quite nice to maybe think about like art programs or artwork to distribute to your colleagues so they can see exactly what has to be done when. Also, they have to be manageable work packages, not too much. It is also important to stay reachable and also transparent. You can think about a kickoff meeting, database training sessions, also maybe build a manual or video how to insert data correctly. And you should be available and for support for upcoming questions and comments. It is also a good idea maybe to have a frequent update meeting, bulletin, and to send reminders for monitoring. And it is teamwork, so you cannot do it alone. This is our team. This is Julia Onken. She set up the study, and I'm working with her. And we have now lots of young researchers, physicians, and students who are working with us at Charité, and also our national and international collaborators. So we have identified lots of work packages that these personnel has to tackle together, like study supervision. We have to screen the patients, enroll them, look for data quality monitoring, collaboration management, onboarding meetings, assess data, also their quality, and make some update calls. So it's a lot of work, but it is a team effort and it is fun. So it is important to stay in contact and update frequently. For example, with recruitment calls, you can send around just to see, okay, it's going, we are still on it. How is it going with you? And make nice diagrams, like for example, where we have all the lesions characterized, we have collaboratively collected. And also, like for example, when the first step is done, you can send around that you are finished and what is to be expected and when, and also be happy together when it gets accepted, or you have the first results coming in, you can discuss it together. So it builds together as a group and it builds visibility over time. Yeah, so the steps in summary, you have to find a topic that interests you and where you are really interested and want to do a lot of work with. Find a knowledge gap with a systematic literature review. Build your context and a publication record that does help. Formulate a concise research question before you start. Find the adequate study design to answer this question, and remember the paperwork. Have a good team to help you facilitate the collaboration, and yeah, stay in contact and update. Make like kickoff meetings, update meetings, be reachable, distribute helpful materials, create structures to monitor and reminders, communicate a realistic time plan, and share your goals and achievements. And thank you very much for listening to me, and I wish you good luck with your project.
Thank you very much, Safir, the well-structured lecture. So I see there is no question in the Q&A. We can check also the chat. So I don't see any questions. Maybe I can ask Vanessa, you have told a little bit about the clinical trial office in Berlin. So this facility is not available everywhere, but would you suggest what type of help they provide you, and what would you suggest to the people who don't have this facility, how they can overcome these all issues?
Thank you for the question. Yeah, I think it is very helpful because when I started, I wasn't aware of all these bureaucratic steps that have to be fulfilled before you can really start. So they helped me a lot. But it were lots of meetings where you have to be present and like discuss what you want to do. They have to understand it, and then they see how they can help you. I don't know if in every country it is so difficult, like in Germany, for example, to get an ethical agreement. So you can start, this has to be done beforehand, and they have lots of things that they need to know before you can start. So I'm not really sure. I think it would be very good to talk with these experts in the legal community before starting collaborations. So I'm very happy that I have this office. Does anybody else have like experiences without the office, how to get this going?
No, I'm envious of you. I mean, in Helsinki, we don't have that kind of help. I mean, we have the research administration of the hospital, of course, but they mainly deal with, giving research permit and I mean, they check the bureaucracy to make sure that you have it. But it sounds like your trial office actually helps you out in designing and realizing this thing, and it sounds like a great asset. So
Yeah.
congratulations that you have it.
It's also with statisticians, they are working with them together. So if you have like questions how to calculate what numbers you need and so on, you can ask them also to help you, which is a good asset.
Yeah.
Because not everybody knows how to do like a case calculation and so on.
Maybe I can ask Harald another question. That was really an excellent talk, combining the clinic with the basic science, particularly working with animal models. It's a tough job in the neurosurgery. Could you maybe tell from your experience to the younger neurosurgeons how you manage all these? Because I have myself some experience, and it's not straightforward, starting from the ethical approvals for animals towards planning the lab and all this stuff till the things work. Could you maybe share your experience? How did you made it happen?
Thank you for the question, and thank you for yes, bringing this up. It's really tough, and I think it depends so much on where you are and in which time of your training or which phase of your career you are. But in the beginning, so I worked in Mainz for a longer period, and in Mainz we had our own lab, but it is kind of low key. So we had almost no money. We had rooms, we had equipment. We were 2 or 3 guys each time, doctoral students and us younger doctors. And most of the work is actually done after hours, in the evening, during the night times, during the weekends. And I think this is how it is in most places. And now I consider myself really lucky to be here in Lübeck, because we have a really modern, nice facility with the staff personnel, with postdoctoral students, and a lots of students getting advice from these staff persons. And it's much easier to do research here than it's in other places. But in the end, it comes down to commitment and actually wanting to do it. And this is what I would tell everybody, every med student, every younger doctor probably. If you have an idea, if you like basic research, you need to take your time, additional to what you're doing in the clinic, and make these first steps. And later on, I think every one of us comes in a position where it's getting a little bit easier, maybe.
Do you combine the biologists to your group? Because transfection stuff and taking the S2 safety labs, this is really a lot of work. Do you combine biologists with your group to integrate some of the basics?
So in Mainz, we had no postdoctoral student. We had no biologist in this means. So it was kind of hard there. I myself spent 2 years in Boston and learned a lot of methods and a lot of stuff that I was trying to teach to medical students and other members of our clinic. But here, so the first thing we did when we came to Lübeck is we hired a biologist to run the lab and to be the holder of all these methods and to supervise all the experiments that are going on. And it made life so much easier. So if you have the chance, I think you should always try to have a biologist or at least other specialties in your lab.
Excellent. I hope this will be a guide for the younger people who are in the process of establishing the lab. Aki, over to you. If there are any questions.
Yeah, Harald, do you still go to the lab yourself?
Yes, I try at least once a week, talk to these guys. I've never held a pipette like for 3 years now.
Okay, yeah. How big is the team in your research group that has actually accomplished the stuff that you showed us? Like the whole team, how many people?
It's usually not more than 3 to 4 persons. So what I've showed was the work, like half of them we did in Mainz, half of it we did here, but usually our lab was 4 persons in total.
Okay, yeah.
So we have very nice comments in the chat, very inspiring talk. Thank you for interesting topics, greeting from Norway. All the good comments.
I think there's one comment that is interesting. Somebody asks about dedicated research time during residency training, because that's something, I don't know, it's at least not common in Norway in our residency program. There's no dedicated research time. I think there is in the US, there's 1 year, I think, in the training curriculum. What do you guys think about that? Should that be kind of a part of residency training that is 1 year that is dedicated to research? Because it's really difficult to combine research with clinical work. We all know that.
So maybe this is also something I can weigh in, because I'm really honored to work with Noreen Carriage as the deputy of our department. And one thing she made clear when she started here in Lübeck is that every resident who has a good idea is getting time away from the clinic to do his research, to start his research. And what I've seen that over a couple of months, nothing actually like bear fruit in the lab from our younger fellows. But then once they get the chance to spend like 6 weeks in the lab, 8 weeks in the lab all together, then actually things develop and their projects really progress very fast in this time. So I think this is, whenever possible, this is a great way to actually have good results from basic science.
At
Thank you.
Charité, we have a clinician scientist program. I don't know if you know that. It's for residents who have good ideas and also like really a project, and they get supported and they can apply for these programs. They are quite competitive, but if you get in, you get 50% of your research of your residency time for research off, and it will not longer your in all program.
Exactly. I wanted to mention the same point. In Germany, there are multiple universities. They have such sort of program where you get some support of 50%, and then you can spend a year or 2 years even.
Although it is a constant struggle to get your surgery numbers. Because of course, if you're in the lab and you have to make your residency in the same time as somebody who does clinic all the time, it's a struggle. But I think it's about priorities.
Okay, we have a couple of more minutes. Maybe I can ask one question to Markus. And the training models, one thing is the reproducibility of the model, but on the other hand, also the variety and variability in the trainees. What would you suggest? What really to consider to have a successful training in both aspects?
Yeah, that's an excellent question, actually. And that also shows how difficult it is to do proper research on the training topic, because there's so many variables that you have to consider. And in the end, I think it's always the question, what is the aim of the model? What do you actually want to train on? And how can we measure what we train on? And that's sometimes really extremely difficult. And as you say, you have, let's say you have a model that you use for first-year residency and residents. It could work well, but maybe it doesn't work for fourth-year residents because they need other training skills and so on. I don't have the answer to that, but I think we have had too little focus on actually evaluating our training in general. I mean, we've been taking a lot of things for granted, but we're not really sure about a lot of things we have trained and done, if it's actually a good training or not, and if it's efficient or not, you know. So that was basically the point of my talk, to show that there is a lot of knowledge gaps and lack of knowledge in these areas. And I guess we could create much better training curricula if we had more knowledge about what actually works and what doesn't work.
Excellent. Thank you. We have a couple of minutes. Katrin, over to you.
I actually think that time is almost up. We had a question from one of our medical students saying, how could you get engaged in research as a medical student? Maybe we can just take a couple of minutes for that.
I think if you're interested, there's always work for medical students in research. If you just want to collect data, or you can help with building some ideas, do the systematic review, you can also publish the paper. There's always things to do. So you can just, if you're interested and you have a topic, you can just write to anybody, I think.
Absolutely, I agree. So with that, I want to thank all our speakers. Thank you very much for joining us, and all our participants for being with us. And we'll announce the next research committee webinar through social media channels, as well as officially through EANS. Thank you very much, and have a good evening.
Thank you.
Bye.
Bye.